Please start the session, Chancellor.
Good evening to all. This is Chandra Mohan, physiotherapist from Sri Samraj Physiotherapy Center, Dindivanam, Tamil Nadu. A warm welcome to all for the EXRX India's and Sri Samraj Health Services Private Limited presenting Webathon, a web series. Enthusing for the world record in the field of physiotherapy, not just counting on topics but responsibly providing the knowledge for the physiotherapists in India and 25 other countries. Apart from this, EXRX India and Sri Samraj Health Services is providing online OG consultation for the women's health related issues in association with Pickle Studio Chennai, Dusa Creations West Bengal and powered by Fitness and Rehab India YouTube channel. Today's EXRX India's topic will be presented by Dr. K M Annamalai. He is Honorable Chancellor, the Gandhigram Rural Institute, Dindigul, Tamil Nadu, India. He is a cardiorespiratory physiotherapist also. He is working in Apollo Hospitals as the HOD Physiotherapy Department, Ahmedabad. He is the first Indian physiotherapist to hold the highest position in our nation as a Chancellor of an university. He is also received Honoris Causa Award from Sikkim Vinayaga University in 2018. He is the first Indian to receive Young Scientist Award from Oxford University. He is the founder of KCAT, that is Kinetic Chain Activation Technique. I welcome Dr. K M Annamalai to present and teach us physiotherapy perspective of COVID-19. I welcome EXRX India team members and all the participants of Zoom meeting and Fitness and Rehab India YouTube viewers. Now I request Dr. K M Annamalai sir to present, commence the session. Please, sir.
So, very warm good evening to everyone, and really sorry for the delay because of due to the technical issue. So, today my topic is, I don't want to say everybody has said morning to evening at least once nowadays. That's called COVID. So, I think everybody having a great idea about COVID because the COVID has been created awareness to the nook and corner of the world, an entire universe we can call it as, not in the world, in universe, because such a strong message it has sent to the humankind that don't destroy the nature. With that message, I would like to start my lecture of COVID in the perspective of physiotherapist. Okay, so first of all, general idea about COVID I would like to share, because we all are therapists, we know about COVID more than a civilian, but yet it's my responsibility to explain in my perspective how I am looking after COVID, because basically I'm a critical care therapist, working many years in ICU in the Apollo Hospital. So now I had a chance to serve to the people of COVID. So it's ongoing process right now. So which has been helped me to understand this COVID little better and depth sense of knowledge. Because once we gain the confidence when we treat the patient and the patient get all right, you feel something like take home message that, okay, I did something great. So such kind of with the satisfaction and happiness, I would like to just share the data and thought process and what are the challenges we faced and how we overcome the challenges and how the case to case difference and how the acute case rehabilitation, how the prevention and how to improve the immune system and how you have to take an ergonomic perspective. And see, physiotherapy is such a Spider-Man web. It can just pull any direction if you want. So such a beautiful subject. So COVID also got into the spider web now. So we are going to see one by one. I would like to share my screen first.
Dumna madam, please allow sharing in case.
Sharing is allowed, sir.
Yeah, I'll do
Thank
that.
you.
Yeah, can you able to see my slides now?
Yes, sir.
Yeah. So first, before I would like to give a small idea about COVID. So first, if you are understanding the COVID perspective, uh, we all are having a phobia and a fear about COVID nowadays because what we are seeing. Actually, there are certain myth and facts are there. I would like to open up the myth and facts first before going into COVID. Let us understand the nature of virus. The first and foremost thing, what is the difference, basic difference between virus and bacteria? See, the virus and bacteria, there are a huge difference. The virus is a non-living thing, actually. The bacteria is a living thing. So that means here I mentioned that living thing and non-living thing difference is the virus cannot be reproduced by its own self and it requires some medium to reproduce or it can to establish its contacts. Whereas the bacteria can reproduce by itself, so it is a living thing. So first of all, we should understand that the whole world is getting fear against COVID, which is a non-living thing. So that's why I used to call it as godly virus because it won't reproduce one more god and it is just creating hell and heaven of a whack around the world. So the virus is a non-living thing. So then if somebody is already died, how can you kill? So that is a big problem, challenges facing by all our medico partners and pharmacological partners and research people and everybody is having that problem that already dead body cannot be killed easily. So that is a very toughest task what the whole world is just facing right now. So I want to say the difference between virus and bacteria. I think you understand that virus is non-able to self-potentially manufacture one more virus on its own. It required a medium to multiply. That's a very important thing. Okay. So the second part I would like to discuss about virus. The virus is a word which we heard since long before entering into physiotherapy field in the 70s and 60s when Microsoft was introduced the word virus in the software system. So why they call it as virus in the software system basically? So there should be some synonyms or simile between the virus, which the word which is used and its physiological function and how it works with pathology, and there is some relation. So I would like to explain with you the first. So this is a round virus, it's a spherical virus. In the spherical virus, you have a lot of spikes. So the spikes are very important, they are actually a kind of proteins. So these proteins can able to clinch easily. It can able to clinch easily, and once it clinch, then slowly it get penetrated into the body. That means it is getting entered into the cell membrane. Cell membrane because the cell is a structural function unit of your entire human body. Okay, so now these spikes are very, very important. So why these spikes are very important? It looks like a crown. It's a corona word. Corona word derived from crown. It looks like a crown of the princess. So it is a corona radiata. It is just radiating corona all the ways. So it is that's why it's corona. And this ring is really sensible ring compared to virus because inside the virus is a dead tissue. It cannot act without the function of this virus around that ring, which is actually spikes. The spikes are a different kind of proteins. All these spikes are fat soluble protein. It is actually fat soluble means when it just clinch onto your body, in your body you have a skin, below the skin you have a fascia and you have a superficial fat, a deep fat. So it is a fat soluble, it can enter into the fat easily. So that's why it can travel easily. So this protein which is enhancing the passing into your cell because it is having a fat soluble nature. That is the beauty of this virus. Whoever designed this virus, even it may be a god, or there is a lot of speculation that it has been made in the laboratories. We do not know. It is not our cup of tea. We don't want to go for that controversy. So whoever designed it is very sensibly designed, because the outer structure of that corona ring, which has a spikes, which is a specialized kind of protein, which is a fat soluble, it can inject into your body by just penetrating the cell membrane, and that's the beauty of it. And what it happens actually, let us stop it here. Let me just have a simile of your computer. So you take a computer. In those days, we use the word virus. Okay. What is actually virus will do? Suppose I'm just using a pen drive, or I'm using a floppy disk which is containing the virus. Once I enter into the system, first of all, this is a virus in the software is something, nothing but it is a kind of a program. It is a kind of a program which is a bad program. We can call it as a evil program or a bad program of the computer. So once this program enter into your hard disk or hard disk, what it will do means it will just disturb the basic operating system of the computer, beginner's operating system, basic operating system of the computer. So when the basic operating system of the computer has get disturbed, so automatically you have a block in the computer doesn't work, or computer get hang, or computer will start to miss, it won't work on your instruction. So this is a normally. So once it become virus, so the entire disk has to be rebooted, and the entire disk has to be washed out and cleaned out, and you have to put the re-enter all the things. It will just spoil all the files, and totally it will kill the computer. So again, you have to relive the computer by booting the new Windows and Windows operating system. So this is, we know about the computer virus. So let us talk to the human virus now. How this coronavirus, this is a very sensible and very intelligent virus. What it does means it just enter into the human body, and it is just have a attraction towards a ACE2 receptors. We have a special receptor called ACE2 receptors, which just mingle with that receptors. It go into the cell. Normally it enter into the cell. So what happens once it enter into the cell wall? Suppose this is a virus, it enter into the cell wall. Normally any bacteria enter into the cell wall, or anything enter into the cell wall, immediately cell wall will start to react to it, and it fight with that. But here what is happening means it won't have any signals to the center of the nucleus of the cell. So it can just penetrate easily into it and enter into it. Once it go into the cell nucleus, nucleus is called a structural function unit of entire cell. It enter into the nucleus, and inside the nucleus it sit inside, and it asks the nucleus to reprint the version of the same virus. It give instruction to the nucleus. So similarly, what I said, the basic data operating system has been killed by means of entering of this program. Same way it is happening. So once it disturbed and it is just start to give instruction, the nucleus of our own cell will start to produce and copy, Xerox copies of this virus more and more and more and more. Then it start to spread all over the body. So that's the way the viral load is increasing inside the body. So it's such a beautiful part how it enter into the body and float into the body, how the sensors work, how it enter into it, and again it is reprinting its version. It's almost like what you can call it as Indran version, kind of it keep on reproduce, and start to spread, and it fight with your immunology system, and it create lot of storms inside the body, and very less amount of people are much affected. Okay, this is one of the fact about the virus I would like to discuss. First, we should understand how this virus functions. Okay, I think you all are well with this area, how the virus get function. So now we ask, use some soap or detergent to kill this virus. How it works? Let us have some common sense. Okay, what is happening? The soap is again, you have a fat in it. It is again having a fat in it, and you have phobia, hydrophobia nature. The soap is having the hydrophobic nature and hydrophilic nature. Both the things it is having. So what is happening means, when we use the soap, this protein will work function opposite, and it create hydrophobic, so the outside ring get degraded. The outside ring get degraded. Once it degraded, this virus inside cannot be done anything. So that's why we are insisting that use the soap, use the soap, use the soap, use the soap, or use any detergent or cleansing agent or disinfectant. All these things are working in that way. Okay. And the second part is regarding the droplet infection. Initial days we had different idea, and day by day new papers and new ideas are coming regarding the droplet infection and spread and other things. I don't want to go much with that because everybody become masters in it, because everybody experiencing, a person who is experiencing the disease will become more doctorate in a particular disease than the doctor. I believe in that. So I think we all are just understanding every day with a lot of effort of government orders and all those things. We learn a lot of things. Okay, this is one of the thing. Okay, so now let us come to the point. Okay, let us have an idea about this COVID. It date of birth of COVID is December 2019 is a date of birth, and birthplace where it is born is Wuhan, China. And what is SARS-CoV-2? What is the name of this? Severe acute respiratory syndrome. Severe acute respiratory syndrome caused by coronavirus 2. That's why it is called SARS-CoV-2. And what is a family? It family belongs to retrovirus HIV. Retrovirus HIV. Actually, what is retrovirus means? It can reproduce with a different virulence, and it has going for a different modifications. So updated versions. So that's why retrovirus. Same the family of HIV. It belongs to the family of HIV. And what is the pet name we have given? COVID-19, coronavirus disease 19, December, coronavirus in December 2019. That's why we call it as COVID-19. Who is his brother? The family brother, they have a lot of family friends, family members. But only one more brother was famous in between. It's called MERS, MERS. That is Middle East Respiratory Syndrome, which was started earlier, little before than COVID, and it has created some impact in the world, but not us like COVID it has been. But he is an elder brother, MERS, that is the Middle East Respiratory Syndrome, was caused by the same family member. Okay, what is the status of coronavirus as such up to yesterday? So 80,000 case in a day we are increasing. So I think we are reaching the world number 1 now. But compared to world population, I think we are just doing good, and we are not having a very heavy load right now. It is actually, see, what is the thing means, we do not know clear about whether we are going to create a herd immunity, or we are going to get a right vaccine, or we are going to get the right medicine. We do not know. But we know that how to prevent ourselves, and once it come, how to manage and how to come out of it. That is a way we have idea. So up to August 30 yesterday, we got 80,000 rise in India a day. It's a very high rise in new cases. Okay, now I'm going to talk about ACE2. ACE2, the spikes protein I said, you can see in the picture spikes protein, SARS-CoV-2 and cell membrane. The infection is just getting through a ACE2 receptor. So it is called cellular entry. So cellular entry and binding of spike protein, receptor binding domain, that is called RBD, receptor binding domain, and ACE2 receptor due to affinity, because ACE2 receptor is having high affinity to CO2, COVID-2. So that's the reason ACE receptor is getting a very important limelight nowadays. Okay. The most fatality rates in the respiratory complication, I give the lungs as a number 1 score, because which is rich with your ACE2 receptors. So ACE2 receptors, where and all there. If you see, our oropharyngeal area is rich with ACE2 receptors. Then if you see, all the blood vessels are rich with ACE2 receptors. Kidney have some ACE2 receptors, and you have lungs is enormous ACE2 receptors. So these are all the areas commonly getting affected by COVID. So the lung is a very sensitive organ to COVID. because the alveolar epithelial type 2 cell rich in ACE2 receptor. So alveoli, in the alveoli outside you are covering with the basement membrane, and the basement membrane is actually given with a lot of pulmonary arteries and veins, and these pulmonary artery and basement membrane in between you have lot of, you can see in this picture, this is actually your alveoli, and this is your actually your capillary vessels, and these are all the basement membranes where this area is rich with ACE2 receptors. So what is the beauty means? The COVID-19 is highly vulnerable to this area. It indicates inflammatory cascade. Inflammatory cascade means like a waterfall. The inflammation keep on continue fall increasing, 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 increasing. It's like a merry-go-round. The inflammation will increase. That's why it is called cascade. Initiate an inflammatory cascade as a part of immunity compared to infection. So infection to fight or combat the infection, the inflammation starts. We know that inflammation is a healing process of the body, but unfortunately, here the inflammation triggers continuously, keep on healing, keep on healing, keep on healing. So every inflammation followed by healing, but inflammation is bad for health. So the keep on cascade of inflammation is reducing compared of infection, which is part of immunity is going down. So the inflammatory cascade, if you see, there is a lot of pro-inflammatory mediators. What are the lot of pro-inflammatory mediators means? To stimulate more inflammation. Pro means to stimulate more inflammation. There is a lot of mediators like the COVID will go and just stimulate. So different kind of cytokines and chemokines will start to produce. The cytokines means the cyto means cell, kines means movement. It is done by some ACE. ACE means it is something like an enzyme. So cytokines and chemokines, and which create more and more and more and more and more and a cascade or a merry-go-round of inflammation, which create a permanent fatal insult to the lung. So the lung tissues are just getting destroyed, or it is permanent fatal insult to the lungs. So this we call it as cytokine storm. What do you call it as? Cytokine storm, because a lot of cytokines are flushing and creating a storm. And this is the main reason for sudden death or young people death or sudden inflammatory has been increased. So the maximum among 5% of the population are fatal. In that 1.5% is highly fatal and they are dying, and immediately they are dying. That is, they are not giving time for us to work on the patient because of cytokine storm. So main cytokine IL-6, which is called interleukin 6, and 1 beta elevation directly linked to the disease severity. So what you can do means, if you find out the interleukin 6 or interleukin 1 beta, if it is elevated, then you can see that the disease is highly severe. So this is what I call it a cytokine storm. So you can just understand that how the storm happens. So you can see that these are all the dendrite cells, right? These flower-like cells are called dendrite cells, and these are called lymphocytes. These are all lymphocytes, and this is these are all the virus. These are all COVID viruses. This yellow color, and once it goes, it produces an inflammatory reaction, chemokine and cytokines, and chemokine and cytokine, and these are all the macrophages and neutrophils. So once it create a storm, this is called actually cytokine storm. So this storm will permanently damage the lung part. Okay, global pandemic. Most patients with COVID-19 have mild symptoms. Most patients. So that's why the beauty is, it is how there is a joke which I have seen that when the fear of phobia of COVID will go away, or when the COVID really will go away, what kind of lockdown we should put. They say that the lockdown is not to the people, we have to put lockdown to the media, because the reason is it has been distorted in a different way and different textures for TRP is concerned. Because of that, the COVID is taken in a very big nature. It took a Viswaroop, we call it as. So most patients with COVID-19 have a mild symptoms. Don't want to fear at all. It's a very, very mild symptoms. Even some people do not notice that they got a COVID. And about 5% develop severe symptoms. They are very, very crucial and critical patients. We cannot leave them, which can be included acute respiratory distress syndrome. We call it as ARDS or stiff lung disease, and septic shock and multiple organ failure, and they become fatal. And many patients nowadays, they found out the kidney involvement is very important, which is there, which is called as acute kidney injury, or you can have a mild proteinuria, and it is a progressive. It is secondary because of it is involving in the epithelial tissue of the arteries and veins. So this is a very beautiful picture which can be shown that one is a cytokine storm, and it can cause pneumonia, that is ARDS, and also it can cause hypercoagulability. That means it is affecting the epithelial cells of the blood vessels. So because of that, it can create hypercoagulability, that is called clot. So that's why the clot is also one of the reason for most of the myocardial dysfunction, and also endothelial dysfunction is a reason for your kidney problem, and ARDS is directly attacking. So these are all the three different area where how the COVID can involve in your body. Either it can create a cytokine storm and endothelial dysfunction, or it can create a cytokine storm, it can create a pneumonia, and also it can affect the kidney indirectly, and or it can create a hypercoagulability, it can affect the heart, or again it can affect the pulmonary hypertension it can create. So this is a beautiful symptom which is a correlation of your lungs, epithelial cells of your blood vessels, and heart and kidney. So this is the areas, that's why we call it as MODS, multiple organ disorder or dysfunction or failure can happen with COVID. So now what is the beauty? This is actually CT chest of COVID patient. So you can see one beautiful thing. You can see ground glass opacity. That is opacity over there. In the computerized tomography of this chest, you can see that the beauty is, see, this is your center part of your parenchymal tissue, and this is a peripheral area of the tissue. So peripheral tissue, you have a fibrosis. You can see the peripheral fibrosis. What is the cardinal sign of CT chest is peripheral fibrosis. Why it is peripheral fibrosis? You see that you have here lot of ACE receptor, and you have ACE receptor at the each alveoli. So alveoli is at the distal end. It is not go through the bronchi or bronchioles. So it is at the distal end. So when I cut the chest like this, so at the distal end of each alveoli is at the periphery of your lung. So that's why, because of the ACE receptors are rich in the alveoli, so you have a what you can call it as the surrounding tissue of your lung. Basically, central parenchymal tissue does not have any change much. The most of the change will have a fibrosis at the peripheral area of the lungs. Okay, then it is a very common, and everybody now know like diabetic test RT-PCR, because everyday media is pronouncing and everybody neighbor is saying RT-PCR. Now RT-PCR become a very normal civilian domain term. So what is RT-PCR? Reverse transcription polymerase chain reaction. This is the expansion of RT-PCR. So, as a physiotherapist, what you should understand means, if you want to understand the severity of the patient, or if any of the relatives you would like to understand, or even if you are going for a COVID test for RT-PCR to the laboratory, you can ask one question: what is CT value of RT-PCR? CT value. What do you mean by CT value? CT value means cycle threshold. It is a cycle threshold. You should have one idea that 24 is ideal. What is that? 24. If it is less than 24, suppose the CT threshold lab fellow is saying that you have 18 or 17. So that means the viral load is more on this body. He is going to be a great spreader, super spreader. So basically from him, you have to take a lot of precautions. So when you want to treat the patient post-COVID, or you want to prevent the COVID, or during the time you are happen to have RT-PCR, if you happen to understand what is a CT value, if it is less than 24, you should take a lot of precautions to treat the patient. And if it is more than 24, suppose 28, 29, 30, so less chance of spread, which is a low viral load in the body. So this is a very crucial thing. You should understand that what is cycle threshold, and CT, RT-PCR 24. Less is more chance of spread viral load more. Higher is less chance of spread less mode. Okay, now let us talk about physiotherapy perspective. Sir, now we talked about COVID, what is the situation and how to understand. In CT scan, what I should see, RT-PCR, what I should see, what is CT value, 24 above and 24 below, what should I do, why I am washing the hand regularly, and because it's a hydrophobic, and all the things step by step. Now we see the physiotherapy perspective. So what are the 4 things the COVID can disturb? So now we have started a program of post-COVID rehabilitation in our center. So mostly third week or second week of post-COVID, we are taking a rehabilitation part. So we are taking a patient of subacute to and chronic. Subacute we are taking in the hospital settings, and chronic and subacute. And after that, the patient post-COVID negative, we are taking in the clinical settings. So what are the 4 physiotherapy perspective regarding the COVID? This is our own experience and ideas from different part of the world we collected and inculcated over here. First one is the endurance. So endurance, strength, independence, and safety. These are all the 4 things regarding the physiotherapy perspective. Okay, what do you mean by strength? If I can just lift this ball, it is my strength. So how many times I can lift up and down, I can hold for? That is called endurance. And suppose I can able to walk, it is my strength. How much distance I can able to walk, that is the endurance. And independence means I don't want any support. Here the supports are totally different. And safety, it is not your safety, it is own patient safety as well as the other safety. Here the safety is different, independence is different, strength is different, endurance is different. That's why I said that the physiotherapy in the COVID perspective. Okay, let us talk about the physiotherapy perspective of endurance. Okay, so primary post-acute care. What is primary post-acute care means? A patient come into the hospital and we are working in ICU, and in the ICU the patient is with a severe stroke, cytokine storm, or patient is in the kind of comorbid or something like that, or patient is just symptomatic and staying in hospital. And what is the primary post-acute care we will give? First and foremost is the patient have a ICU acquired weakness. So ICU acquired weakness means the mobilization will be tough and your muscle will be weak, and patient is just completely, because of viral load, the patient will have completely dull and aches, pain, irritability, all these things will be there. We call it as ICU acquired weakness, and we otherwise we can call it as post intensive care syndrome. It is called PICS, post intensive care syndrome. The most of the patients what we have seen in COVID is in post acute care, mostly they will have twin problem called dyspnea and oxygen desaturation. Dyspnea means difficulty in breathing, and also oxygen desaturation means even a small movement if they perform, the oxygen will drop. The saturation of probe, you can see that SpO2 will drop. These are all the 2 I's which you can see in endurance perspective of physiotherapy. That is dyspnea and oxygen desaturation. What about the strength? If a patient is normal ICU patients, comparatively in COVID patient, the muscle mass loss is very fast, which we found out. So the muscle mass is falling very fast, and we see the reason why the atrophy is more faster than the normal ICU patient than the COVID ICU patient. We will see the reasons behind. So there is a loss of muscle mass which we are seeing. And the other physiotherapy perspective is independence. The very important part is early discharge to free up the hospital space. Nowadays, the over number of patients are increasing. So the hospital has to do a cyclic rolling because the beds are not available. The population comparatively, the population in geometric progression, whereas our hospital beds are less than the arithmetic progression. So basically, we want to discharge the early patients to give a care to the really much needed and intensive patients. So because of early discharge, the patient almost go in a subacute care. So the patients are not fully independent at home. So they need support of physiotherapy for some time, for extended period of time to become at least to a minimal capacity. And sometimes subacute is hard for independence. Sometimes subacute is hard for independence. So if it is independence is very hard, right? Because some subacute, if you send to home, they need a person, but they have to be isolated. They will be in a room. They have to get up. They have to walk. They need some support. They have to go to bathroom and they should not sleep. So the independence is a question over there, because the normal people cannot support, because they will keep the distance away from it. Early discharge and the patient of full independence is not possible at home without the help of people. So how much they are going to take care of them and how much they are going to take of their own safety, all these things are a question. So that's why here the physiotherapy perspective, the independence is having a different role. And the physiotherapy perspective, if we talk about safety is concerned, the one is a therapist safety, other one is a patient own safety. So here the weakness is there is a chance of fall and decreased endurance and decreased independence and put them greater risk of fall. So the more chance are falling, because mostly COVID is affecting the age-old population. Already they are compromised with the Berg balance score and their balance has been reduced and muscle weakness were there already, and also they have a low endurance capacity, and all these things are just a cherry on the cake is your COVID. So the COVID, in that the people, the home members cannot support them unfortunately, because they have to keep their distance of their own safety. So all these things are going to affect their safety. Okay, now let us talk something about oxygen regarding the COVID in the perspective of physiotherapy. Most of the patients with COVID-19 will require oxygen supplementation for post-acute care. Most of the patients, I'm not saying less patients, most of the patients. The goal to take out of them oxygen support. What is the challenge of the first challenge of the physiotherapist on post-acute care rehabilitation is how to deactivate or slowly withdraw the support of oxygen. I said already that here the support means not only orthotic prosthetic support, the oxygen is also a support. So we have to slowly wean off the patient from oxygen. The oxygen saturation should be monitored very closely, because even a small movement also will go for a deconditioning effect and create oxygen depth, and immediately patient will go for a collapse. So oxygen saturation should be monitored closely, SpO2. Okay, what is a very important area about the strength? The specific viral load. Few viral load will just kill the strength very faster, and a certain viral load will just have slow sustaining losing of strength. So the specificity of viral load will be responsible for the strength changes, and prolonged lack of oxygen to the muscles. So nowadays we are just using the mask every now and then for our safety is concerned, and the children who are born in this era, they may feel that it is a private part, that's why we all are closing, maybe in the future. So such a way we are closing throughout the day when we are outside. So what is happening means it acts as a rebreathing bag. Whatever carbon dioxide we just thrown out, the little bit of CO2 is just get sucked inside. So this actually reduce your oxygen capacity, and the muscles are getting a very less amount of oxygen. So that also cause, normally even a mask habit is also creating a little bit of muscle weakness. And moreover, prolonged lack of oxygen to the entire body because of the COVID and because of lung affected because of ARDS and epithelial cell changes at your what you can call it as your um, alveoli. All these things are changes in V by Q mismatch, and due to V by Q mismatch and pulmonary hypertension, the end of the cell does not get the right kind of perfuration. So because of that, the cell will go for a low oxygen. So the mitochondria will be less powerful. So this can leads to a oxygen depth in the muscles. So muscles can go for dying. That is called atrophy of muscle. The longer period of increased respiratory rate and heart rate and decreased partial pressure of oxygen, that is saturation, and prolonged bed rest, these are all the various reasons for reduction of your strength. And what we can do, how we can test. So we can use the muscle test traditional guideline. So how we can see, first we have to see the anatomy of the muscle. So we have to see the anatomy of the muscle. We should have an idea about comparatively before COVID what was its muscle nature and what is it right now, and how much the girth of the muscle has reduced, and what is a, you can use a MMT scoring, manual muscle testing scoring, which is a very traditional guideline, and these two things has to be taken care. And functional strength assessment is also very important. While gripping or grasping or just punching or pulling or pushing, what is a functional strength assessment also you should look after. And the loss of weight and loss of muscle mass should be taken into account. So here you cannot consider all the muscle wasting because of that, or loss of muscle wasting or loss of muscle mass or loss of body weight. So here the body weight means it included muscle, that is a protein, as well as other components like your fat and other things, and fat and fluid level and everything. So we should find out whether the patient is having a loss of weight or loss of muscle mass. Two things are very important to identify and have a different accountability for treating it separately. Now let us talk about the independence. So if you want to find out really right way of independence of the COVID patient in acute post-acute care, first you should look for Barthel index. The Barthel index will give you the activities of daily living, how much he can able to operate, what is his tolerance capacity. You can go for 6-minute walk test to identify, and transfer mobility grading, whether he can able to transfer independently by himself or he needs some assistive device. And assistive device here including your oxygen mask or BiPAP or saturation has to be monitored regularly. All these things are also here assistive device. Family support, and how the family is supporting, whether they are just completely neglecting the case or they are just over cooperating with the case, which is also again a drawback for developing the oxygen depth in the body, and environmental support. All this thing has to be taken care. And let us have an idea of safety. Teach patients self-monitoring of the vital signs and other symptoms, because here the very important thing is you cannot be around the patient always, because your safety is also very important. The more amount of exposure to the patient with you, you will have viral loading more. So always you should teach the patient how to monitor his BP, how to check his heart rate, what is his Moore score, what is his saturation level, how to monitor which is actually alarming saturation level. Once saturation level is alarming, what he should supposed to do, and he should understand what is fatigability, and he should know changes in temperature of the body. All this thing you should teach them, whether they can self-monitor. It is more easy for the patient for the outcome measures. Okay, now let us find clinical perspective of physiotherapy. So clinical method to find endurance. First, you look for shortness of breath, whether the patient is breathing. Suppose you're asking, what is your name? My name is Murugan. So what is happening? He is just using a shortness of breath. So how much he is just using a breathing? He is very fast, shallow breathing, or is a rapid breathing? You should identify. And signs of pallor. Any cyanosis is there. The patient is very what is sluggish and response is low, and the salt imbalance is there. All these things are very important. And baseline dyspnea progressive with mobility. Suppose patient is coming to me and I know some dyspnea is there, so I can just see that whether his saturation level is how much saturation level. So once a saturation level is fine, and when I start to do exercise again the saturation level is dropping very fast, then baseline dyspnea progressiveness with mobility has to be identified. And postural controllable hold their head or trunk up. So in order to keep their head and trunk up, they need a good effective role of diaphragm. Diaphragm is a twin joint muscle. It is a twin function muscle. It is maintaining your posture, upright posture of your body. Same time it is functioning for your breath. So suppose in COVID, due to the challenge of oxygen depth, if it is recruiting lot of diaphragmatic shallow breathing activity, so diaphragm lose its postural function. So the patient may feel sluggish or fall or something, not able to keep your head high or spine high. So that postural control has to be looked after. And breathing pattern should be looked, whether the breathing pattern is very high breathing pattern or easy and effortless breathing pattern or slow effort breathing pattern, that you should look after. And adaptive device and equipment utilization. So whether the patient is comfortable with continuous monitoring of saturation or continuous given of oxygen, or with the BiPAP, we have to look into, or something like a, you need a stick or a cane, or he is having a, or he's having a what he can walker or something. And functional mobility skills. So how much he can able to mobile by himself, how much he need a support from the family, and the activities of daily living in the active and bed mobility, transfer, ambulation. All these things are clinical perspective of physiotherapist should just notice. Okay, what is a physiotherapy perspective in nutshell means? Mobility, strength, endurance are the three parts. So simple. So if you have a low strength in small muscles, normally small muscles will lose the strength fast. So strength is losing automatically. You cannot walk for a long time. So endurance will lose. So once the endurance is loose, your mobility will lose. Once the mobility is loose, further strength will lose. It's a vicious cycle. So we have to attack at one quadrant to reach the patient in a better way. First, whether we have to work on strength, then we have to work on endurance. Automatically, the outcome product is mobility will increase. So how you can just able to do, what is the scoring sheet you can just use? Modified Box scale can be used to understand the patient how he is expressing. That means is actually in 8 to 10 is a very dangerous zone. That means your mobility should be micro mobility and slowly you have to build up the endurance. Suppose the patient is between 5 to 7, you have to be give a little conscious challenges. Suppose patient is from slide somewhere to 2 to 4, then you can just reach to the challenges level of threshold. And 0 to 1 means you can just go ahead with all your equipments and all your regular rehab work and everything you can do. Okay, what are the consideration regarding the oxygen is concerned? First, we should understand, did patient use before COVID oxygen? Some patient may use the oxygen before COVID also, we may not know. So in that patient, we cannot fight to get the lungs better than the before. It is not possible because already the COVID has created a cytokine storm and insulted the lung. So it is not easy job. So we should understand the pre-history, that did the patient use COVID oxygen before COVID oxygen usage, and less or more or now comparatively. Before, if they use less oxygen or more oxygen comparatively to now, we should have that idea. And use for all activity and rest continuously. Suppose a patient, we are giving a domiciliary oxygen or a nasal probe or a mask or venturi mask, or you're giving a breathing bag or whatever it may be, you should understand that whether the patient saturation is dropping with oxygen during all the activity or during rest continuously also. So if the patient is having a desaturation of SpO2 even at rest, then it is called newer classification grade 4, which is a very severe patient. Suppose a patient is having a desaturation happening when he is doing exhaustion activity or something. So then it is actually, if it is a 4 means, yeah, and if the patient is having activities of daily living, he is taking bath or is just going to bathroom, is getting breathlessness, then newer classification 3. A patient is going for a marketplace, cycling or running or walking or star climbing, then it is a grade 2. And the patient is having, suppose, for example, even normally when he exhausts too much on sports, then it is grade 1 of newer classification breathlessness. Either you can use newer classification breathlessness or you can use a book score classification. But I use newer classification, which is more easy in my perspective, whereas in patient perspective, the book score is much better. The use for all activity and during activity only, whether the patient required oxygen or while sleeping also patient required oxygen. What is the prescribed level of oxygen? What is the delivery method? That also makes sense. If you have a nasal prong or you have a mask or you have a Venchi mask or you have a rebreathing breath, that's very important. You should understand. Depends on that, you can titrate the oxygen and saturation for your activities. What is the resistance training? This is for your strength. So here I always use your gravity as a resistant training unit for initial, because you don't want to sanitize anything, you don't want any equipments, and the isolation can be done easily. Like simple exercise like sit to stand, or you can just stand and walk for a few steps and marching at the same place, and use your wall pushing or something, like use gravity. And free weights, if you have a personal TheraBand, personal weight or personal sandbags, you can use, or water bottles of you personal can be used. And functional movement training, you can give a lot of functional activity as a movement training, that you walk up to the kitchen, you walk up to the bathroom, or you just take off your own shirt and just you can use it. And consider the activity induced hypoxia. What are the activities and how much metabolic equivalent is required, which is creating hypoxia, has to be compared with the metabolic equivalent scale, MET scale. And quick to fatigue, which activities are fatiguing him quickly. You have to create that activity be done purposefully with breaks. So that is very important. And low weight, more repetition is a key in COVID rehabilitation. Low weight, more repetition. Progression based on the patient response. It is nothing dictum. It is purely depends upon the patient response, because it is a highly dynamic disease. What are the comorbidities? So what are the other comorbidities can affect your COVID? So COVID, the COPD, so your main function of physiotherapist, you should think a patient with COVID with COPD, then you have a lot of sputum to remove it. So airway clearance is your main area. And if the patient is having a resistive lung disorder, the chest expansion is not good, the breathing pattern is not good. So then you need a high oxygen supplementation and you have to create oxygen depth with the challenges and slowly you have to bridge the gap and you have to get back to the patient to the normal endurance level for resistive airway. And heart failure. So in heart failure, already heart is failed to pump the cardiac output properly. So the BP should be regularly monitored if the patient is along with COVID. If a patient is having a coronary disease, suppose the blood circulation to the heart is called coronary disease, and if there is a CABG has done or there is a post PTCA has been done, percutaneous transluminal angioplasty are already done or stent is there, so then you have to maintain your saturation very higher level. Suppose I am just giving workout for a normal patient between 90 to 100. Suppose if a patient underwent PTCA, then I should take a risk of range between 95 to 100. I should keep the more perfusion to the heart. And pulmonary hypertension, keep again saturation level high to do the exercise, so that you have a very less window period of gap for exercise. Next is breathing retraining. Oh, it's very, very important, breathing retraining. I use the great workout of your balloon. So if I can able to blow the balloon, it is a fun with the patient can do by itself own. So how much you are just able to push the air out, that much your diaphragm will get recruited. And inspiratory muscle training is a key for anything, because the inspiratory muscle is one of the muscle which is affected. That is nothing but diaphragm. Diaphragm is a great wall of China between your thorax and abdomen. So sometimes because of the spoiling of this inspiratory muscles because of COVID, what is happening means the patient will have a reflex, that we have come across. Some patient will have a reflex problem. So the reflex is because you can esophageal sphincters are controlled by function of your diaphragm. So the diaphragm is relevant to your esophageal sphincter reflex. So basically in that patient also, if you just encourage a lot of deep breathing or diaphragmatic breathing, so that kind of reflexes can be controlled. And accessory muscles has to be shut down by giving lot of facial therapies. You can give lot of mobilization and you can give lot of functional activity to those muscles while breathing. You can just correlate with the function, and at the same time you can just give some relax massages you can give, and you can give some myofascial releases and tapes can be put down. So you should know how to shut down the accessory muscles, because the accessory muscles, they are not meant for your breathing, so they will take more energy from your body, so the oxygen depth will increase, further it will increase your breathing difficulty. And pulse sleep breathing is one of the beautiful, you should just teach the patient, because pulse sleep breathing will conserve the energy and V by Q matching will be happening much better. And diaphragmatic breathing, again, it is stimulating a parasympathetic activity. So your sympathetic shutdown will happen. So once a sympathetic shutdown will happen, automatically your body will become more parasympathetic. So your almost all your endorphins will just produce in your body, morphins will produce your body. That will keep you a soothing of your body, which will help you to turn to heal the body fast. And paced breathing, that means with the exercise, with the movements, how much you have to pace the breathing, inspiration, expiration, you have to switch on, depends on the what you can call it, and fun with the balloons, I said. So the one of the immune booster physio solution, my favorite one is any patient to prevent. What is the prevention method? So in the prevention method, I say that if you are not come across with COVID, don't stay at one point for a long time. Sitting is a new smoking. So every 30 minutes, just have a micro walk. 5 minutes walking for 40 minutes. It's called micro walk. The consistency is a key, which will keep your epithelial tissue beautiful, and also the ACE inhibitor more inhibited active. And I think this is one of the immune booster workout. You can just walk regularly. Okay, the final part I would like to say that this is your actually your core, and in the core you have a diaphragm at the center. So diaphragm is an inspiratory muscle. So when it is inspire, it goes down. When it is expire, it comes up. Inspiration, expiration, inspiration, expiration. So now you can see that the upper part is also a circumference, This is nothing but your air entry of your oropharyngeal area. The highest architectural barriers are there. Still, it is open. And also here the base is your basically your pelvic floor, and these are all your abdominal muscles. So you know this is actually a cylindrical core. So what is happening is normally this diaphragm is functioning is normally it do up and down. Normally for breathe it normally it is a postural muscle to keep the trunk erect. But when there is a lot of need of respiration, more pumping of oxygen it requires, it start to function very high way. So when it function high way for your purpose of your respiration, it lose its purpose of your balance and posture. So that's why in the post patient, the post COVID patient, we are going for Berg score monitoring. The patient will have a loss of balance. So we have to work a lot of ranunculum balance exercises which can be helpful for the patient to improve the function of diaphragm. And functioning of diaphragm, if we just breathe out, breathe in, and we train that, that will improve the function of your balance. The balance and diaphragm are part in part each other, hand in hand together. So that's why that is one of the area you have to look after. And the remaining things I know, you know, vitamin C, zinc, and all those things are out of my cup of tea. And because all those things are chemical substance, I don't want to talk anything regarding that. I just today, because it's a time is gone now. I want to share only the post acute care rehabilitation. Now we are working on our post care rehabilitation of post negative rehabilitation also, and those is again a different kind of spectrum. Hope I think I did justice to the topic which they have given, and really amazed to be here. I'm sorry for my delay at the early stage, and yeah, now I can go for the question answer. If you have any questions, you can ask me now. Thank you.
Thank you, sir. Thank you so much, sir. Very nice session. And that it is a need of hour also, because lockdown is getting diluted, and most probably we may treat post negative, COVID negative patients also. So, very wonderful, sir. We will go for the question and answer session. Participants, please, if there is any questions, please, yes, I will unmute you. Yes, Shankar sir. Yes, Shankar sir, please, you can raise your questions, please. Come on video.
Yes.
I did unmute.
Hello. Sir, good evening, sir.
Yeah, good evening, sir.
Sir, regarding COVID issue, sir, I'm working in the COVID ICU, sir, right now. So what are the role of biomarkers, especially the inflammatory markers, and the role of active and passive physiotherapy, sir?
Sir, D-dimer is one of the area you should look after. If there is the D-dimer is one of the area where you can see that how much the coagulability of the blood can be understood. So if the coagulability is more, then D-dimer value is higher. So then you should have a more kind of prioritized for a low dose heparin, what they will do chemically. But we have a low dose heparin physically, that is called ankle pump exercises. And every micro level we have to give for every half an hour. We are keep on just inducing them to keep on work something. So the mobility is one of the key for controlling the D-dimer. And the second part is again interleukins. Interleukin 6 is again an inflammatory marker. So inflammation is one of the sympathetic activity. So we can induce a lot of parasympathetic workout like inducing the diaphragmatic breathing, which can control the interleukins in a better way.
And just for second question, sir. Yes, sir. So regarding whenever they're asking for the passive movements or whatever exercise, sir. So usually what we study minimum 3 days to muscle going for weakness or acquired weakness, sir. So sometimes when we the right time to select that patient to give the.
Okay. So the first and foremost is you should see that hemodynamic stability. Number one, the word is hemodynamic stability. What do you mean by hemodynamic stability? Means the patient saturation level can be compromised to an extent. Patient the Bogue score should not be 1 to 3, and patient is already on ventilator. Sorry, no, the patient is on the oxygen or the saturation is too fast. Desaturation is very fast, or the patient is having a comorbid of hypertension or something that is not stabilizing and the heart rate is not stabilizing. All these things are medical problems. So I call it as hemodynamic stability is the first key to understand. And once the hemodynamic stability is controlled, it may be on first or second or third day. And what is a outcome measure over here means, compared to I have seen in my ICU, compared to other normal ICU patients of neurological ICU patients or normal head injury patients, compared to that, what is happening means these patients are going for fast wasting of muscle and fast shrinking of muscles. Maybe because of lack of oxygen for a mitochondrial preparation. So the muscles are wasting fast, I think so. So I think you can passive, you can give earlier in that way, not a issue. Earlier you can give a passive, but later on you can start active. And in this active also, first if possible, patient can just sensitize that areas. You can give a sensory re-education, or you can just give joint compression or something like that, which is passively you are giving your own energy where the patient is moving. I think it won't be desaturate much. The passive movement can be started earlier, whereas the active and active assisted movement can be later on. Even hemodynamic is not stable also, passive movement doesn't make a big difference.
Okay, sir.
It is good actually. It works as again a heparin.
Apparent. Okay, sir. Thank you, sir.
Yeah.
Thank you, sir.
Thank you so much, sir. There is another one. Will read it out. The question is from Lavi Sharan. Virus is very small. How it cannot enter from mask? Why do we wear mask?
See, virus. This is actually a controversial question nowadays because we use mask. For example, we use in ICU we use a N95 mask with a shield and everything. So those things we can just consider that because the dress itself, even air is not able to understand to go inside mind kind of easily. So in that sense, there is some sensibility is there. But the mask which they are wearing is it's to at least if somebody is just having a sniff or somebody is going to have a what you can call it as a sneezing. So the rate of traveling of virus can be resisted to particular distance rather than going a long route. Maybe that is the reason.
The same person have asked another one more question, sir. Uh, Maybe coming in the WhatsApp also some video was circulated. I have seen video regarding holding breath. Is it true that person who hold breath more than 20 to 35 seconds is not COVID patient?
See, it is a very preliminary method of physical examination, we can call it as. It is a self-monitoring method, which can you help? Suppose I have a fever. I'm a civilian. I'm not knowing idea about anything about medicine. Suddenly I have a little bit of fever and I have a running nose. So immediately I get fear because the entire media has been rattled me with the COVID. So what will happen means I will have a fear in my mind. So the fear is a worst thing in the body, which will create what you can call it as steroid into your body. That is actually called cortisol. So this cortisol is acting as a immunosuppressant basically. That will just pull all the virus as a host inside. So what is happening means, unfortunately, this kind of media inputs and the people inputs and the social stigma will start to understand that I have some anxiety, whether I have it or not. I have it or not. Going to lab, little bit confusion. Going to hospital, little bit confusion. To whom I should ask, what I should ask. So during this time only this kind of signals are getting picked up in the WhatsApp and other things. These are all the small method of operation to understand that lung is having a breath holding capacity or not. So nothing but when you are just holding the breath, what is happening means if the lung tissue is not damaged much, parenchymal tissues are not damaged much, then only you can able to hold it. So this cannot say that you don't have a COVID, but this can say that you are not having a severe COVID or there is a cytokine storm is not there and it is not a severe case. At least you can understand that if you can hold it, you can feel that okay, I am the mild case or I can be a moderate case. But severe case cannot be hold on this. So with that idea only they floated that video. I think so.
Thank you, sir. The next question is from Suresh Balaraman. Breathing exercise help to prevent COVID or help to reduce the chance of getting COVID?
Can you question me again? I couldn't hear you.
Yes, sir. Yes, sir. We'll read it again.
Yeah, tell me.
Yes, sir. Please wait. Yes, sir. From Suresh Balaraman, breathing exercises help to prevent COVID or help to reduce the chance of getting COVID.
Okay. See, the breathing exercises is basically it helps to prevent the COVID because the reason is how much you are going to breathe in, breathe out beautifully. So you are going to have a good oxygen saturation in your body. So the microcirculation has been enhanced. Once a microcirculation is enhanced, your immune system is much better. That is the one area what we believe that the circulation will help to improve the microcirculation and it can enhance the beauty of your all the vessels are pumped with the proper kind of balance the chemicals. So that is one of the advantage of regular breathing exercise. And regular breathing exercise is a reserve volume. So you can call it in other way. If you are doing a regular breathing exercise, even if COVID comes, you have more chances for escaping from that, and you have a less severity of impact. So that means what you can call it as means bad time is there, but you have some area to reserve for yourself to have a less impact. Something like they said, na, astrology, the things are not good. At least you go to that temple. So if you go to that temple, at least you have a change of mindset. That's an area. But it is evidently it is improving the microcirculation, activating the parasympathetic activity. All these things are helping you for reducing the fastness of the disease spread as well as the inheritance of the disease and inculcation of the virus. Definitely it is helping.
Thank you, sir. Rupesh, can you read the next question? Okay, I will read it. The next question is from Lavi Sharan. Everyone says that sanitize everything. Do sanitization kill coronavirus?
See, sanitization, again, I'm saying that outer protein cover, I said that the protein cover. So the sanitization help to decay that layers. See, sometimes they said if you don't sanitize, you don't have a facility to sanitize, keep that particular thing without touching for 48 hours or 24 hours. What will happen means that corona ring will, that protein will get decayed by itself. If it is not decay, you are just spraying something. What is happening? The coronavirus chances are that is actually just demantle the outer spectrum. So because of that, if it clinch, it cannot enter inside. So that is the reason all about the sanitization.
So there are so many appreciations, sir, and even one from Satyanarayan from Melbourne. And yes, sir. The next question is from Mohan Rasu. How to recover COVID-19 patient? No proper vaccine and medical treatments, sir. How to kill virus?
I said that a dead body cannot be killed again. Simple as that. So you don't want to kill the virus. See, how can you treat diabetes? Diabetes is a functional problem. So similarly, this is again going to be a functional problem. I think in my perspective, because the world is going towards a vaccine, we are going towards, see, if we consider flu is concerned, seasonal flu, whole world is taken vaccine. India never took a vaccine we didn't take much vaccine. So, but still the flu was not much disturbed us. But India, they have a herd immunity. I think the permanent solution is herd immunity, which we can learn from the history of Spanish flu. And the second part is, I think the vaccines are the temporary means which can help you to, whether we do not know still it is under the construction. So we do not know how much it is going to increase our IgG. So we have to be sit and finger crossed. We have to wait for it.
The next question. The next question is from our YouTube viewer, Vijay Nambi. Some studies shows that post-COVID patients are more prone for complications. What is role of physiotherapists to prevent that complications?
Yes, I said actually now physiotherapy is going to be a huge caretakers of this post-COVID patients. That's why I said it is a huge chunk if you see the business perspective also, because Most of the patients post-COVID are having a problem of, because I've treated more than 60 to 70 patients now. Most of them, now I'm doing a outpatient rehab also for around 14 patients. They are so sick patients, and their saturation will fall to 90 even for a MET of 3.5 to 4. So in that such a cases, I can understand that the restrictive, it behave like a restrictive lung disease, and also it is impact on the epithelial tissues. The epithelial tissues are widely spread around your vessels, blood vessels. So definitely the rehabilitation play a major role, and also it is going to affect the fascia, posture, and your coughing method, and your just see basically what is happening means the endurance, strength, and all those things. What are the factors which I just spoken that all these things are what you can call it as means you can understand, you can see, but you neglect. That is a part. That is actually a problem. Actually, you know these all are important, but the patient also will neglect. Even therapist also will neglect. What is the big thing in this? It's not like that. These small things you can definitely see the changes, big changes in COVID patients, which I'm experiencing now. Future, I think it's a huge chunk of patients, and post-COVID comorbidity can be contained by regular proper rehabilitation of respiratory rehabilitation or pulmonary rehabilitation. I think the pulmonary rehabilitation is going to be a huge area going to crack the deal in the future.
Okay, the next question. Next question is from Professor Mayura Deshmukh. Sir, being the physiotherapist, we treat patients with very close contact with the patient, especially in case of bronchial hygiene. So sometimes we may be the asymptomatic carrier. So in this condition, how to take care of ourselves and our family members in order to prevent the spread?
First and foremost is if you are going to work in bronchial, you're talking, I don't understand, you're talking about the real bronchial secretion of a normal condition or bronchial secretion with the COVID virus. I don't understand. But in the case of COVID virus, what you should do means, I always suggest that if you are working in hospital setting in ICU, mostly they will practice a close suction method. Close suction method means already this suction is it covered with the tube. You don't want to put your this thing directly holding the catheter. So it is a close suction method is always good. So you can opt for that. Suppose in case of bronchial hygiene, in case of COVID, if you want to come to patient, and you should have a low viral load. Low viral load means unnecessary, unwanted things you should not touch patient. Rather, I don't want to. You don't want to go and do a percussion if a patient is having a restrictive lung disease, because you are taught that percussion has to be done to all the chest PT. It is not mandatory, because in restrictive lung disease, it is actually a matter of oxygen inhalation. It is actually it is basically a reflex, or it is a matter of your diaphragm recruitment. So, suppose if the patient is having a COPD comorbidity, then there is a sputum is there, then you have to work on. So, you have to identify where I should. So, rather than working hard, you should work smart to understand where you should use it with a less input and more outcome, which is a mechanical advantage. Second order liver, you have to work like in physiotherapy. And when you go to home, and I think you just take all precaution. You should take a vitamin C and zinc, and also you should take bath. And if you have a separate room, you isolate yourself. And once 1 or 2 weeks of your duty has completed of a viral loading, then you can come out on weekends and enjoy the family. And family, the childrens are fine, and old age people you should keep a distance. And you can speak with them with the phone, video calling. You can use the technology nowadays. I think you should find out the way. Where there is a will, there is a way.
Thank you, sir. The next question. The next question is from Shantanu Malik, a physiotherapist from Bangladesh. So, non-smoker, sir, I have gotten some information from John Hopkins University, Sweden, that was more than 15 minutes stay with positive case can only spread the virus. Is this true?
See, there is a study, even I read that study, that is basically your smokers and non-smokers. Basically, smokers, they have a nicotine inside. The nicotine is carry your virus, viral load. There is a difference they are saying, but it has been studied in a very, very minimal group. It is not a maximized group. So still it is on the questioning. We cannot be taken into the practice kind of, but it is an information that's it. We cannot consider that as it is because a very small group, and it is the sample is very less sample, and yeah, you cannot predict that with the smoking is concerned in that. But anyway, the nicotine is going to create a vasoconstriction. Again, it is going to create a epithelial tissue problem. Already you are going to have epithelial tissue problem. It is a volcanic eruption for your COVID. I think you stop smoking. I don't want to have any justification for smoking at this stage of COVID.
Thank you, sir. The next question is from Suresh Balraman. Sir, give some precaution steps to handle patients in outpatient physiotherapy department for physiotherapists.
Outpatient physiotherapy department, two things. If you are going to do a patient once the patient is just getting into your premises, check for your temperature scan. Number one, you write the temperature because these records will help you for any given day if there is any problem of government affairs comes. And you check for you can check for ask the patient to you give a balloon to the patient, ask him to breathe fully in and look for chest expansion and all these things. You can just look at basic thing and check for saturation SpO2. Agar if SpO2 is between 95 to 900, it's fine. And patient have any other symptoms or fever or something, then any tiredness, fatigability, look for those things. And there is any cyanosis is there or something like that, you can look into it. These are all can be. And if the suppose a patient is having a COVID without any symptoms, asymptomatic COVID, I think they are going to have more than 24 the value of your CT value. So don't worry about it, they won't spread much, but still you have to take a precaution of yourself. You should stop cross infection between the patients. So you should just use sanitize your ultrasound head, and if you want to use a short hair, use a towel. There is a cloth, this paper towels are coming to use as a spacer, and you can just use for a what you can call it as every time you can change the bedspread of the papers. Bedspreads are coming, and if you are going for any manual therapy, only if it is required you give a manual therapy. Otherwise, don't give manual therapy. And you teach the exercise by keeping some distance. And during the exercise, if you are going to be aerobic exercise, don't allow him to do the mask, and keep equipments between the social distancing. And apart from that, once in your cabin, patient comes and go, immediately sanitize your cabin with your seats and where the patient sat and other areas. And again, you call for a next patient. I think this is called new normal. We have no option. We have to do it at this juncture, and soon we'll get some more ideas.
Thank you, sir. The next question is from Johar Mayan. Post-COVID, which should be our priority? Fasting or endurance?
Again, question.
In post-COVID, which should be our priority? Strength training or endurance?
Endurance. Any given day, endurance. But endurance can be gained by giving challenges to the strength of a small muscles, not big muscles. Don't look for quadriceps. Don't look for hamstring. Look for small muscles like fingers and wrist and rotations and neck. It looks funny, but this makes big difference.
Thank you, sir. Duna madam, is there any questions in YouTube? Kindly check, please.
No more questions, sir.
Thank you, madam. Participants, any other questions?
Oh, one question is there.
Yes,
One question
please.
is there.
Please post it, madam.
Yeah, plus.
From Professor Shankar Ganesh, as you said, COVID is restrictive disease. So ballooning and bubble won't harm patients?
See, what I'm saying means it's a restrictive disease means it is ARDS, Adult Respiratory Distress Syndrome. That's why we call it as SARS, right? So SARS means stiff lung. So if you are going to balloon, you are focusing here. The ballooning is to improve your diaphragm. So the diaphragm is an inspiratory muscle basically. So we are not going to work. See, the diaphragm we are going to train. So once a diaphragm is going to train properly, so what is going to happen means the scar tissue can be healed much better. So that's the reason we are selecting ballooning is one of the.
Okay, sir. The next question is from. Hello.
Yeah.
So the next question is from YouTube viewer, Mr. Vijay Nambi. Is there any chance for recurrence of COVID for post-COVID patients?
Yes, there is a chance. Now they found out that actually, but very rare cases. But still, they are not clear with the herd immunity too. But there is a few cases in my practice also. One case actually COVID negative. He was discharged after 3 weeks. Again, he got a fever. Again, we checked. He got again he got a diarrhea and all those things. So we found out that the residual virus is staying sometime in alimentary canals. So that is also one of the things. Very few cases are reported, but you don't have a clear perspective about that yet.
Okay, sir. Any other questions, participants? I think no questions. We will conclude it. Duna madam, any other questions on YouTube? We will conclude.
No questions, sir. Please conclude.
Yes, sir. Thank you so much, sir. Thank you so much for a very informative session. Actually, we never take a COVID topic in our webinar sessions because it's just now it appeared and don't know whom to approach. So I myself thought that you are the right person to teach us about COVID, and thankfully that you are also accepted our invitation to teach us actually. Thank you so much for a wonderful session, sir. And I thank EXRX India team members, Dr. Rupesh, Professor Duna, and Vairo Sudasan, and other team members, Ms. Simran, for their wonderful help to run the show. And I thank all the participants from our Zoom meeting and also from Fitness and Rehab India YouTube viewers. And I thank Dr. Annamalai sir once again. Thank you so much, sir.
So I would like to personally thank you all, Chandramogan and Rupesh and Duna ma'am, because Duna ma'am is doing a effortless, it's actually thankless job actually, because she is, I came to know that she is not a therapist, but she is dedicated to this field. Really, I hats off for you, madam, for a wonderful job. Really, I'm happy to hear to run this record. And once again, I would like to congratulate you all for your successful on September 8th and advance wishes for a happy World Physiotherapy Day, and be proud to be a physiotherapist. Thank you so much.
Thank you so much, sir. We will expect your presence on the world record event episode. Please be there with us, sir. It is a happy moment for all the Indian physios actually. So I expect you to be present at least at the moment the officials which were announcing it.
Sure, I'll try my level best. Thank you so much for your wonderful organization.
Thank you, sir. Thank you so
Thank you.
much. Thank you all. Good night.
Thank you very much, sir. Good night, sir.
Yeah, thank you, Rupesh.